more participants to join, then maybe I can just start with some housekeeping item. And first, I'm Karina from WHO Headquarters, Department of Immunization, Vaccines, and Biologicals. And thank you for joining the second last session of this series of webinar on COVID-19 vaccine costing, budgeting, financing, and delivery. And today's topic is COVID-19 vaccine impact modeling, key issues to know about modeling evidence to inform prioritization and delivery. And next slide, we will look at some housekeeping items. Okay, so we are offering an interpretation today in both French and Spanish. Excuse me. And you can access by clicking on the globe icon at the bottom right of the Zoom toolbar and selecting the language that you would like to hear. If you only want to hear the interpreted language and not the original language in the background, click on the mute original audio button. Next. We are looking forward to all your questions and comments. Please place any technical questions in the Q&A feature, which is just to the left of the CC icon. If you have any logistical or IT questions, please put that in the chat and the ECHO team will help out. Next. We are also offering live transcript, which is only in English. If you are interested in seeing that, click on the icon between the Q&A and the interpretation icon. And choose shows subtitle and captions will appear on the screen. To close that, just click hide subtitle. Next. Just as note about the recordings and certificates of attendance, this session is being recorded and your attendance is consent to be recorded. Thank you for that. And the recordings in English, French, and Spanish will all be shared afterwards through follow-up email and as well as the TechNet21 website. And the link will be shared in the chat. The certificates of attendance will be available through the University of New Mexico, where Project ECHO is based. They will share a link to that at the end of this, in the chat about 15 minutes before the end of the sessions. There will be a brief survey that should take about 3 to 4 minutes to complete. Your feedback will be useful for internal quality improvement and you will obtain certificates after completing the survey. Next. A note about the data used. The data collected is taken very seriously and the data you provide will be all aggregated and de-identified before sharing with WHO. Next. Okay, so before introducing today's session, I would like to have some pool questions with you all. Can ECHO team please help open up the pool? And let's have some interaction here. There will be 4 questions that we would like to understand from you. And you have to scroll down to see all the 4 questions. And the first question is, in which WHO region do you work? African region, Eastern Mediterranean region, vaccination modeling in your region or country? You can answer yes or no. If yes, please, can you put in the chat what model you have heard of? Third, have mathematical models been used in your country to guide national policies regarding the optimal use of COVID-19 vaccination in combination with public health and social measures or non-pharmaceutical interventions? And you can choose yes, no, not sure, or not aware. And last questions, how familiar are you with WHO stage processes for developing evidence-based vaccination recommendations? Very familiar, somewhat familiar, or not at all familiar. You can keep answering the questions, and when you are responding, let's move to the next slide for the agenda and objective. Today is the second last session of this series, and next week we will have the last session on global status update, a year in reflection and a year ahead. Registration is already open, and you will find the registration link in the chat. Next. For today, the theme is COVID-19 vaccines impact modeling. Dr. Raymond Hudubasi from WHO will be the moderator of the session. He will first talk about how COVID-19 vaccines impact modeling can be served as an input for decision and policy making. And second, Dr. Sarah Pellis from CDC, also the co-chair of the SAGE working group, will provide an overview on the SAGE working group on COVID-19 vaccines impact modeling. And the other co-chair, Dr. Nicholas Grassley from Imperial College London, will summarize the results from the WHO Commission's COVID-19 vaccine modeling. And last but not least, Dr. Nick Scott from Burnett Institute will present the country examples of COVID-19 vaccination modeling. Next. The goal of today's session is to share the most recent modeled evidence commissioned by WHO and its role in decision-making, more specifically aiming to describe global level processes for reviewing and integrating modeled evidence into WHO COVID-19 vaccination policies and strategies, share findings from recent modeling work on COVID-19 vaccination strategies, strategies commissioned to inform WHO SAGE, and highlight key considerations for commissioning and using modeling to inform COVID-19 vaccination decision-making at regional and national level. Okay, so before handing over to Raymond, I would like to go back to the pool result. Can ECHO team please open up the result? I think most of you should have answered the questions. Okay, good. So the majority will be from African region and also European and Southeast Asian region. Welcome all. And then, okay, around half of you not aware and half of you aware of the vaccination modeling in your country and region. That's good to know. And if you put yes, it would be great if you can also put in the chat what modeling you have heard of. Okay, and then for the third questions, okay, 35% of you have the mathematical models used in your country. And then for only 16% of you familiar with the WHO SAGE process for developing evidence-based vaccination recommendations. Thank you very much for your participations in the poll, and I think you will learn more from this session. And without further ado, my pleasure to hand over the microphones to Dr. Hudubasi to start the first presentation. Raymond, please.
Thank you, Corinne, and thanks for the introduction, and welcome all to this webinar on COVID-19 vaccine impact modeling as an input for decision and policy making. So on the right-hand side, you see a cartoon I liked from the daily French newspaper Le Monde, where, and I'm sure in all your countries, you are aware of the use of mathematical models to inform policymakers, decision makers in your countries on the strategy to fight the pandemic and how modelers have kind of forecasted the pandemic and anticipated how to deal with the pandemic. And what I would like to go with you through in this introductory talk is give you an overview of what the questions are for scenario modeling, what the scope of these models are, and what type of models are currently out in the field. The second part of my introduction is referring to a project we started last year on comparing COVID-19 epidemiological models and what the lessons learned were from that project for policymakers and for mathematical modelers. And then the last part, I will focus on the tailoring of the global strategy on COVID-19 vaccination and the role of modeled evidence. Next. So when you see on the scenarios to be modeled, it's important to ask questions of what decisions need to be made and by whom. And here on this table overview, you see that there are decision makers, policymakers at global, region level that ask different questions and that need perhaps different types of models. And what we all see is that most of the modeling teams help decision makers with questions with regards to the goals to be set in terms of the health goal or the economic goals, but then also then at the global level to tailor this down to the region level and provide guidance to the regional situation. Also at the country level, this goal setting is important in order to identify the strategy, the optimal strategy to PHSMs. So that stands for public health and social measures, with or without the availability of COVID-19 vaccines. And so scenario modeling can also look at the impact of the different interventions compared to a baseline. What we also see is that at the global level is that scenario modeling has been used for technical guidance to countries on intervention themselves, like PHSMs, vaccine use or testing, but also to coordinate global activities or regional activities on research or data sharing, pooled procurement. And last but not least, also what you see in many of the models at the global, regional, country level is with regards to the optimal use of scarce resources. Can be financial resources, but also, for example, on human resources, how to use these scarce resources within this pandemic that are attached to the different strategies countries have. Next. When it comes to, next slide, please. When it comes to scenario modeling, you also see that the scope of the models can be different in terms of geographical scope or temporal scope. We see models, and you will also see this later on in the webinar, that some of the models address multi-country issues or cross-country, cross-border effects issues, and are able to also to disaggregate the results by region or by income. Some of the modeling teams only focus on a single country within a specific context, and sometimes they're also able to look at the outcomes at the sub-national level to identify equity considerations for marginalized populations, rural versus urban areas. And so this is kind of the geographical scope of these models. On the temporal scope, you see models like the forecast models, who typically look at the forecast of the pandemic in terms of a 1 week to 3 months, or might go, when you then go over the 3 to 6 months, these are more kind of the scenario projections and the typical what if questions, and what if you use this strategy or vaccination strategy in combination with PHSMs at different coverage levels, what are the projections? We also see models that go over more than 1 year. And on my next slide, you see an overview of the different modeling groups, teams that have been addressing these different issues in terms of scope. What you also see there are a list of key uncertainties across all the mathematical models. It doesn't surprise you to have the viral evolution towards greater transmission, immune escape. This is an issue that is a key uncertainty, but also the duration of protection from natural infection, but also from immunization. Vaccine effectiveness, another key uncertainty. And then also the political, economic, and social feasibility of introducing these public health and social measures is a key uncertainty. Next slide, please. So this is just an overview and illustration of models and modeling initiatives, model teams that address the different type of questions at the global, regional, country level across different time horizons they cover. So the forecasting models from up to a weekly forecast to 3 months, and you see a couple of examples in the cells here. at the global, regional, and country level, but also at the scenario modeling from 3 to 6 months, or up to 18 months, or even longer to 5 years. And I won't go to all the details on this slide. You can see in the different cells, the modeling teams, and modeling groups who have been addressing different questions to inform different target audiences. But here today in the webinar, we are focusing on the what-if scenarios, scenario modeling for the WHO SAGE group, working group on COVID-19 vaccines. And most of the models address questions up to 3 to 6 months or to 1.5 years from now. Next slide, please. So just some lessons learned from the CMCC, the COVID-19 multi-model comparison collaboration. We started last year with the World Bank, the Gates Foundation, and the IDSI. So this work resulted in 2 publications: a technical report on the fitness for purpose assessment, and a policy report for policymakers. And the reports are, the full reports are available on the links below, but also on the WHO on the Decide Health website. Next slide. So from the technical group, one of the issues we discussed, and that came out of the discussions between the different modeling teams involved and policymakers, is that models need to be fit the purpose. So decision makers, policymakers do have a question, and which models are available out there, or maybe not available, to address the question. But even going back, whether a model can address a specific question is the first question you need to address before trying to identify whether existing models can help you with your decision. And so here, and I won't go to the details of this flow chart or decision tree, but it really addresses questions policymakers should come up with, or analysts, that has to do with the policy aims, the modeling feasibility, model implementation, or model reporting commitment. And it really helps you to identify whether there are mathematical models out there to help you with a specific question. And on the next slide, please, you see that another kind of recommendation and conclusion from the CMCC is that during this whole process of setting up the model, identifying the decision problem, decision question, identifying the scenarios, the parameters, the data, but also the calibration, policy formulation, interpretation of results, this needs to be a close collaboration between the decision makers and the modelers, and even the wider community of partners and funders involved, and general public perhaps. This is really important in order to address all the issues in this whole process of developing the model, setting up the scenarios, and helping also the modeling results and making them interpretable for non-modelers. And this, I think, is an important issue. And on the next slide, please, you see for both groups, we came out with a set of recommendations. And I think here, the key here is also that for policymakers, so the question whether modeling tools can address the policy question is important, but also for modelers, to have identified concrete approaches to involve policymakers and analysts, in particular from low middle income countries, in the development of the model or the adaptation of the model, in order to make this model fit for purpose, and also to have ownership of the results coming out of these models, and to use them to guide policy. Next slide, please. So just a couple of slides on the global strategy and the tailoring of this global strategy on COVID-19 vaccination. Next slide. So you might be aware that the WHO Director General came out earlier October with a global report to achieve global COVID-19 vaccination by mid-22. He came up with this, the report refers to the 10, 40, 70 targets to get the global community and stakeholders aligned in order to achieve more broad coverage and equitable distribution of vaccines worldwide. And in the light of these global goals and strategies, WHO has also encouraged countries to set their own goals and targets based on their own country context in terms of demographics, epidemiology, where they are in the pandemic, or also the program reach. Next slide. And to help countries, we also have come up with this goals framework. It's a conceptual framework that helps countries to set their own goals and the targets in terms of vaccination, or also in PHSM's, public health and social measures. And I think the main message from this goals framework is that the level of vaccination is not a goal of in itself. It really serves this higher dimensions and goals on health or socio-economic goals. So what is the goal of a national government in terms of health, in terms of reducing COVID-19 mortality and protect health workers, or even a higher goal in terms of reducing disease burden and limit health systems impact or reduce viral transmission. And on the horizontal axis, you see the different socio-economic goals countries might have, and as a result of having a full lockdown to going back to normal. And in this whole surface here, countries can move and with their level of vaccination in terms of coverage and the priority groups from the blue to the red upper right corner, and have different ways of scaling up vaccination. And can you please go to the next slide? We also have, based on this goals framework, we have tried to come up with a step-by-step tool or guidance to help countries in identifying their optimal vaccination strategy, also in a time where, if for your country or your region, vaccines might be of limited supply. And so these are the steps. And again, I won't go into detail, but the importance here is that in step 4, when countries also need to define their health and socioeconomic goals, mathematical models can help countries quantify the health and economic consequences of vaccination strategy in combinations with the PHSMs, and help countries to help with their decision making on the trade-offs of health and non-health. Okay, so let me stop here. Next slide, please. Happy to answer any questions you might have in the Q&A. And let me get back to Corinne or Sarah, who's the next speaker. Thank you.
Thanks, Raymond. We don't see any questions in the Q&A at this time. So in that case, next slide. So thank you. My name is Sarah Pallas, and I'm presenting today in my capacity as a member of the WHO SAGE Working Group on COVID-19 vaccine. And Nick Grassley and I have been chairing, not the working group, but a subgroup of the working group on impact modeling since June of last year. Next slide. So this is just to give an overview of the WHO SAGE process for COVID-19 vaccine recommendations, which has been a bit more accelerated and has produced some different kinds of outputs than are normally produced by WHO SAGE for other vaccines. So we started last year with a values framework, and then that was further informing a prioritization roadmap for using initial limited supplies of COVID-19 vaccine to optimize impact. That was not a product-specific recommendation. So as COVID-19 vaccine products became available late last year, there have been individual interim recommendations for each specific product. And then through the course of 2021, as new issues have emerged, cross-product issues, SAGE and WHO have issued interim statements as well as good practice guidance on topics including heterologous series, booster doses, vaccination of children and adolescents, fractional doses, and some of these are gradually incorporated into the product-specific recommendations as evidence accrues. So that's the overall optic. Next slide. And WHO SAGE, I should mention for those who aren't familiar, is the strategic advisory group of experts on immunization. So it's a set of external experts who advise WHO on immunization policy. And so for each vaccine, typically SAGE is creating a position paper for the use of that vaccine. And for COVID-19 vaccines, we created an evidence framework to show how different pieces of evidence would contribute to that eventual SAGE position. And modeling has been one of the critical elements of the evidence to go into this. It has not only informed the specific product recommendations as well as the prioritization roadmap, but is also feeding into a variety of questions that lead us towards the ultimate position on the optimal use of COVID-19 vaccines. Next slide. So in order to review the evidence available on COVID-19 vaccination impact modeling, the working group formed one of 3 subgroups specifically dedicated to looking at impact modeling. This subgroup has had several activities over the last 18 months. The first is developing and putting out requests for information and commissioning modeling work through requests for proposals from WHO. The second is having presentations to the impact modeling subgroup, which have been done on a weekly basis over the last 18 months, and a summary of these findings for the SAGE working group on COVID-19 vaccines and for the SAGE, and then including also the commissioning and collaboration on the systematic review of the modeling literature. You see at the right of the screen a table just summarizing the models that have been presented to the working group through this format from a wide variety of geographic settings. Next slide. So we issued a request for information on existing and ongoing COVID-19 vaccination modeling in mid last year. This was in July, and this was very helpful to begin to have a landscape of what different groups around the world were doing. And we had 20 modeling groups that responded to that from academia and government and nonprofits, addressing a number of the different questions that were included, which range from the health impacts of vaccination to the social and economic impacts to equity to cost effectiveness. And you can see in the colored stacked bars on the right, this is showing that there were some topics that many groups were working on, and there were other topics that were less well addressed. Also, the distribution of the geographic areas that were being modeled was a bit different. So in particular, we saw fewer models that were addressing low and middle income country settings. So each color bar there is a high income, upper middle income, low income country setting. Next slide, please. So in order to better systematize this, we worked with the London School of Hygiene and Tropical Medicine there with Anna Vassal and Mark Jitt, and others there who conducted a systematic review of the vaccine prioritization modeling, because this initial request for information was to inform the WHO SAGE prioritization roadmap on which groups in a population should be vaccinated first to maximize the health impact, but also considering these other factors from the values framework of the social and economic impacts, of the equity considerations. And what they found here, and you can see the link to their preprint, is first of all that there was limited evidence for low and middle income country settings, that the findings from the modeling largely concurred with what was put forward for the SAGE prioritization roadmap. So this work went into 2021. The SAGE roadmap was first issued in December of 2020 and then updated later in June. And across all of these models that were reviewed, it was found that prioritizing older adults, older groups within a population would minimize death, although prioritizing younger groups in a population would minimize infections and cases. There were few models that incorporated all of the risk groups of interest from the prioritization roadmap, including, for example, essential workers, individuals who faced higher risk of infection due to their occupations or due to their residential setting. There were also few models that explicitly included individuals who faced higher risk of severe disease and death due to other health conditions, other comorbidities. There were also very few economic evaluations and few models that were considering equity. So in order to address some of these gaps, next slide, WHO issued a request for proposals in January 2021. This had 18 questions to be addressed under 5 topics. And that's what we'll be covering for the rest of today's session, is looking at some of these preliminary results. Just to orient you to the 5 topics, which were intended to fill in some of the gaps identified from the request for information and prior systematic literature review. This included vaccination strategies to maximize in-person schooling, which was topic 1. Topic 2, vaccination strategies to keep health system use below a peak capacity level. Topic 3 was looking at settings that had at that point no cases and the feasibility and impact of outbreak response vaccination. Topic 4 was looking at the potential to lift public health and social measures, also called non-pharmaceutical interventions, without causing further outbreaks and without exceeding certain measures, for example, of health system capacity. And topic 5 was considering how to optimize the impact from the supply of available vaccines, particularly considering dose intervals at that moment between the primary series, the first and second dose of 2-dose primary series, and more recently considering booster dose schedules, as well as the mix of products and whether certain products would be best targeted to certain types of subgroups in the population to maximize impact. Next slide. So I'm just showing here, we had a wonderful response to this request for proposals from many groups all over the world. 8 groups were selected, and representatives of these groups are on the line with us today to answer your questions. And we just really want to take the opportunity to thank and appreciate the work of these teams, which they did, many of them under very tight time constraints and while being responsive to stakeholders in their own countries. And you see here the settings that each of these groups modeled, as well as the topics that they covered. Next slide.
Sorry, Sarah, just to interrupt.
Yes.
Can you speak a bit slower because interpreters have difficulties to translate? Thank you.
Thank you, Raymond. Thank you for the feedback. So here I'm showing, again, Raymond mentioned the global strategy to achieve COVID-19 vaccination by mid-2022. So this is a WHO strategy that was published in October, but the work on this was ongoing throughout 2021, and modeling from the groups represented on the call today and in response to this RFP were used to inform this development of the global vaccination strategy. In particular, one of the key findings related to this progression from older ages to younger ages, which you see in the graphic on the left. So moving in step 1 from vaccinating older adults and high-risk populations, then to step 2, vaccinating all adults, younger adults, and then only then in step 3 to vaccinating adolescents, and then younger than adolescents, vaccinating children and pediatrics is really an area where there is still certain uncertainties that need to be resolved. But importantly, the modeling from the groups helped us characterize the types of trade-offs between vaccinating different groups of the population and achieving different levels of coverage, and how that related to the potential for the social and economic impacts, which you see in the second row, moving from these public health and social economic goals that Raymond described from the conceptual framework in terms of reducing mortality and severe morbidity and hospitalization as a first set of goals, to also resuming socioeconomic activity, and then expanding vaccination as a tool to reduce transmission and also future risks of the emergence of new variants. So this was really a global level strategy to inform coordination and investments across countries. And as Raymond mentioned, there is a new guidance document for country level adaptation and tailoring of the strategy to inform how to take this overall strategic approach and put it in the country context for specific goals and coverage targets. Next slide. So here, this is a very busy slide that I won't walk through in detail, but it's just to give you an example of modeling. This was done by the Imperial College London team, and Alexandra Hogan, the lead author, is on the call today. And this was an example of modeling that was used to inform this global strategy development, and really looking at, for different age groups, what might be the impact on mortality, what might be the impact on hospitalizations, what might be the impact on infections, and looking at those across a different country income group settings. So in this slide is showing that type of analysis for high income countries at the top, upper middle income countries, then lower middle income countries, and then low income countries at the bottom. And we looked at this in a variety of scenarios and sensitivity analyses, and it really helped to quantify some of these potential impacts and trade-offs at the global strategic level. So really just an example And this was presented to WHO SAGE in June and again in October. So just really that we had the opportunity to work closely with the Imperial College London team and other teams that are on the call, the Doherty Institute and others, to show and characterize some of the trade-offs in different types of vaccination strategies in different settings that could lead to a strategic approach that was then endorsed by WHO SAGE. Next slide. So this is my last slide before passing over to Nick, and I just want to mention here a few topics that have been identified both by the SAGE working group as well as the IVRAC, which is the Immunization and Vaccines Related Implementation Research Advisory Committee. And this is another advisory committee at WHO that reviews economics and modeling work to help inform WHO and SAGE. And these topics include more modeling needed on booster doses, more modeling needed on vaccinating adolescents and children, in particular risk benefit and cost effectiveness. And there is some work ongoing, but probably more is needed to really look at the integrated models across epidemiological and economic trade-offs, in particular, the impacts of public health and social measures to control transmission and how those in combination with vaccination may have impacts on the broader society. There's also a need for longer term models that are considering the quote unquote end of the pandemic and the transition to endemicity, and looking at different thresholds to monitor that over time, as well as, of course, the impact of novel variants of concern. So this is a bit of a future-looking agenda that WHO and other partners will be pursuing. Next slide. Thank you so much for your attention. Happy to answer any questions on what I've covered, and otherwise hand over to Nick.
Thank you. Thank you, Sarah, for this excellent presentation on the process. I don't see any questions in the Q&A, so I suggest we continue with Nick, who will present the results from the RFP we issued earlier this year. Over to you, Nick.
Thank you, Raymond. Well, I just wanted to highlight one of the comments in the chat was, can we have a link to the economic modeling as well, from Mohammed Humayun? And I don't know, Sarah, if you wanted to just comment on what we reviewed in terms of economic models and you know, the comment you made that there was less economic modeling available to us at the time we were reviewing this work.
Yeah, thank you, Nick. Yes, so there have been a few cost effectiveness analyses of COVID-19 vaccination, and we can include some of the links to that in the chat or via the WhatsApp group or after the webinar. There is also a new initiative with WHO with the Health System Governance and Financing group at WHO in combination with other partners such as the World Bank to look at integrated epidemiological and economic models. And this effort is really trying to have both for this current response to COVID-19, but also to prepare us for responding to future health threats and considering the impacts across the health sector and other sectors of the economy. So that some of that work is ongoing and not yet published in a publicly available format that we can share, but it is coming, and we'll look forward to sharing that soon through the different channels of communication that have been set up by ECHO. Raymond, please feel free to add anything else.
No, thank you. Thank you, Nick, also for reminding me of the other chat. So there are different channels ongoing here, so to manage, but thanks a lot. And also reminding us on the EpiEcon work. So Nick, back to you.
Thank you, Raymond. Yeah, lots of chats to monitor. Next slide, please. So what I would like to do is just present some of the highlights from the modeling work that was done in response to the RFP, the request for proposals, that Sarah Pallas mentioned. The modeling groups are on this call as panelists, and so I would encourage you to direct questions to them about some of the work that I'm presenting. And of course, given the time limit that I have, I will just be sort of highlighting a few key findings, and I apologize in advance to the modeling groups if I misrepresent anything, but I'll try my best, but we'll certainly be ready to hand over to you for any detailed questions. So next slide, please. So just as a reminder, these are the 5 topics that were included in the request for proposals. We commissioned 8 modeling groups to address these, who addressed different topics and different questions within these topics. And in this highlight, I'm just going to focus on topics 4 and 5. And actually, I'm going to start with topic 5. Next slide, please. Next slide again, please. Thank you. So a key question through 2021 has been around how we might maximize coverage of available supply of vaccine. And one of the options available to countries was to delay delivery of the second dose in order to maximize delivery of first doses. And in particular, delaying that second dose beyond the 3 to 4 weeks interval that was used in the clinical trials that then led to licensure of the early vaccines that were available. So a simple insight from considering the maths of vaccine impact is that if the first dose effectiveness, VE1, is at least half that of that offered by 2 doses, then one should prioritize that first dose delivery to as many people as possible before delivering second doses, assuming that all individuals are equal in their risk of severe disease following infection. Next, please. But of course, not all individuals are equal in their risks of severe disease, and the roadmap prioritizes those who are most vulnerable early in vaccine delivery, and that gives the greatest benefit. And of course, going back to those most vulnerable groups with the second dose is important and perhaps should occur before delivering first doses to the less vulnerable, typically younger adults. Next slide, please. It's also possible that one dose, that the immunity offered by 1 dose of vaccine will wane more rapidly than 2 doses. Next slide, please. And so at the time we issued the RFP, there was a little bit of work on this topic. And I'm just highlighting an illustration from some work that was done in the UK that led to that informed the JCVI decision to delay delivery of second doses for the AstraZeneca and Pfizer vaccines as those vaccines were rolled out. And this illustration just shows an optimal deployment of 1 and 2 doses in the UK under the assumption that the relative efficacy of the first dose compared to 2 doses is 70%. And so what you can see here is that delivery of first and second doses to the very most vulnerable individuals in care homes is optimal, but then subsequent delivery to those over 80 and healthcare workers shown in red, for the delivery of that first dose should be followed by delivery of a first dose to those 75 to 79 before going back with a second dose into that high-risk group. And you can see that pattern continue as more doses become available. So in response to our request for proposals, we saw some really great modeling work. Next slide, please, addressing this question. So this is an example from the London School of Hygiene and Tropical Medicine, Yang Liu and Kaya Abbas and others who modeled the impact of different dose delivery strategies on COVID-related hospitalization and mortality in 13 middle-income countries in the European region. And they focused on 7 different delivery strategies. The strategies A1 through to A5 just correspond to different intervals between the first and second dose from 4 weeks to 20 weeks. The strategies labeled B1 and B2 involved delivery of all first doses to older adults, and then delivery of second doses once all older adults have received their first dose, before then offering first doses to younger adults. And the second strategy, B2, corresponds to delivering first doses to the whole population, before then delivering second doses to the older adults and then younger adults. So in practice, strategies B1 and B2 correspond to substantially longer intervals between the first and second dose. B1 to about 6 months and B2 to about a 12-month interval. And that's illustrated in these graphs on the left here, which show coverage with 1 dose in blue and 2 doses in red. And you can see the delay in delivering the second dose as you go from A1 to A5 through to B1, B2. Next slide, please. Just briefly to summarize, of course, all the modeling works needs to make assumptions about vaccine effectiveness or efficacy, and just highlighting here that the efficacy of a first dose here was assumed to be relatively high compared to delivery of 2 doses. Next slide, please. Okay, so under the assumption that the first dose protection is persistent with a mean duration of protection of about a year, 360 days, actually for nearly all the countries, the B1 strategy was the one that resulted in the lowest cumulative mortality, and that's shown in the graph on the left here, with generally an increased interval between first and second doses, offering lower overall mortality as a result of the pandemic. Next slide, please. If first dose protection had a shorter, persisted for a shorter duration, so in other words, if there was more rapid waning of immunity from that first dose, then a strategy with a shorter interval between doses, in this case, with 12 weeks between the first and second dose, was optimal in terms of reducing mortality. Next slide, please. So of course, all the modeling groups did sensitivity analyses to the assumptions that they made. I don't have time to present much in the way of detail for all the work that we've reviewed. Just highlighting for this piece of work that sensitivity analysis was done to the presence or not of a variant of concern corresponding to Delta, to different vaccine products with different effectiveness for the first and second doses, where vaccine effectiveness depended on the interval between the doses, as we've seen for COVID vaccines, and for the different rates of waning of first dose effectiveness, which I showed you on those 2 graphs. Next slide, please. We also reviewed work from Alicia Cray and Ben Lopeman at Emory University, focusing on the same question, but 6 low and middle income countries. So this is this graph on the left here is an illustration of the impact of vaccination with a strategy that offers either a 24-week interval between the first and second dose or a 12-week interval. And if I ask you to focus on the bar chart on the right here, this just shows the numbers of deaths per million after 180 days of the simulation of this epidemic. And of course, with no delivery of a second dose, so the number of deaths is the highest. For a 24-week interval between doses, the number of deaths is reduced, but the optimal strategy here was a 12-week interval between doses. And they didn't look in this case at shorter intervals between doses. Next slide, please. So just summarizing that work across those 6 countries, you can see that the percent of deaths averted for the 12-week interval between first and second doses was greater compared with the 24-week interval. This particular result is based on the assumption that public health and social measures remain in place until 80% of the target population received at least one dose. Next slide, please. Again, sensitivity analysis was done by the group. They found that the result that favored a 12-week interval was consistent for most rollout speeds of vaccination for the range of vaccine effectiveness assumptions that they looked at. Although I note that the single dose vaccine effectiveness was at a maximum 66% of that of 2 doses. So perhaps somewhat less than the values assumed by the group at the London School of Hygiene and Tropical Medicine. And so that contributed to some differences in their conclusions. And it's these kind of different approaches and differences in assumptions that can really help us make sure we draw robust conclusions from the modeling work when we want to inform policy on these key issues. The 24-week interval was favored over 12 weeks in only one case, which was where the rollout speed was very, very low, 0.01% per day. And the group also looked at the potential for just a single dose to boost naturally acquired immunity from previous infections in high seroprevalence settings. And they found that in that case, that did favor the longer interval strategy in the very short term, but in the long term, a 12-week interval still did better. Next slide, please. Okay, so that was the work on dose interval. Within this topic, we also asked about whether there was an optimal allocation of vaccine products within countries by, for example, risk groups or age groups. And so I wanted to highlight here the work from Emma McBride, who developed an online tool. The web address is shown in the bottom right here, which allows you to explore the impact of different vaccination policy decisions, including the use of different products in different age groups. So the graphs here on the right show the numbers of infections in the top row of graphs and numbers of deaths in the bottom row of graphs as a function of increasing vaccination coverage with for the left-hand column, Pfizer vaccination only, for the middle column, AstraZeneca vaccination only, and on the right, the mixed strategy. They also, this tool also allows you to explore different vaccination strategies in terms of targeting the most vulnerable first, shown by the green line, a random distribution strategy, or focusing on younger adults who may contribute to transmission. And you can see here, the numbers of deaths are minimized by giving vaccines to the most vulnerable in agreement with the prioritization roadmap. Okay, next slide. Okay, I wanted to briefly also cover the fourth topic. This was a question that was coming to us, to the WHO SAGE from countries about to what the extent to which vaccination will allow them to lift non-pharmaceutical interventions or public health and social measures as they're now referred to. Next slide. Thank you. So this is just some work from Jodie McVernon, based in Australia, showing, looking at whether public health and social measures can be lifted while still maintaining the reproduction number for SARS-CoV-2 below 1, which would be the threshold for control of transmission, or at least elimination of transmission in the community. And you can see here that the estimate for the basic reproduction number of Delta was 8. And so to reduce that down to 1 requires both baseline public health and social measures, test, trace, and isolate procedures in place, vaccination coverage, and then different levels of more stringent public health and social measures. And as you follow those bars to the right, you'll see an increase in vaccination coverage. And even at 80% vaccination coverage, to bring the reproduction number below 1. Some low levels of public health and low to medium levels of public health and social measures will need to be in place with this new variant. And indeed, it seems to be the case that with Delta, and I suspect even more so with Omicron, we will not be able to eliminate transmission in the community. This is going to become an endemic disease. Next slide, please. The group at Imperial College, led by Alexandra Hogan, also addressed this same question about the impact of lifting public health and social measures at different levels of vaccination coverage, and also at different levels of previous size of the epidemic. So here's an example for Thailand, showing the estimated reproduction number over time in the blue line here in the top left graph, and a prediction in the bottom left graph of the number of deaths over time if in the future some public health and social measures are lifted, or public health and social measures are fully lifted in the rightmost column. And for Thailand, who previously have had relatively low numbers of COVID deaths, you can see that fully lifting public health and social measures is predicted to lead to a large epidemic in 2022. Next slide, please. Here's the same graphs, but for Spain, where previously COVID has spread widely, seroprevalence is higher, and you can see here that fully lifting public health and social measures will lead to an increase in COVID-related mortality in 2022, but the increase is much smaller. So to some degree, past exposure combined with vaccination will allow some, but not all, public health and social measures to be lifted. Next slide, please. Okay, I just have 2 more slides here. This is work from the Institute for Clinical Effectiveness and Health Policy in Argentina, who looked at the same question as well as other questions in our request for proposals, addressing whether or the impact of lifting public health and social measures at different levels of vaccination coverage. And just to highlight here, on the top graph here is the predicted number of hospitalizations requiring intensive care for a scenario where public health and social measures are lifted once vaccination coverage reaches either 50% in the topmost graph or 80% in the bottommost graph. Oh, sorry, I've actually explained that in the wrong way. The public health and social measures were relaxed at 50% coverage or 40% coverage. That's shown by the green and orange lines. Sorry, the orange and green lines respectively. The blue line shows where the scenario where public health and social measures are not lifted, and then the 50% and 80% refer to the uptake of the vaccine. What I wanted to highlight from this graph is that in 2022, even with some lifting of public health and social measures, the numbers of hospitalizations can remain below both the 70% threshold shown by the dotted line here. Next slide, please. And this is my last slide. This is work from India, from Ashoka University in collaboration with Johns Hopkins University, just showing the impact of the timing at which public health and social measures are lifted, indicating that, of course, as you delay lifting public health and social measures, peak hospitalization rates are reduced. So that's the trend along the x-axis there. And for higher rates of vaccination, going from the black line here, which is no vaccination, through to 0.8% vaccination of the community per day, the peak hospitalization, the peak in hospitalizations is lower, and public health and social measures can be lifted earlier. This is based on a detailed agent-based simulation model. Okay, so next slide. And just to say thank you for listening. Those are just some highlights from some of the work that we've seen. As mentioned, the modeling groups are on the call, and I'm sure will contribute to answering any of the questions that you may have.
Thank you. Thank you, Nick. It was a great presentation. And I do see some Q&As, questions in the Q&A, and some of them have been answered. I'm not sure we have time to maybe address one live here. Is the vaccine going to be annual vaccination scheme? What are the recommendations? Older only or for everyone independent from the age group? This is a question by Lucy. And also a question by Mohammed on how countries will be supported for modeling accuracy and hiccups during the process. Don't know, Nick, you want to answer?
Yeah, I mean, to the extent that I can. So the roadmap that was released by WHO SAGE gives a prioritization scheme for delivery of vaccine up to 50% coverage of the population. So that lays out who should receive vaccine as supply becomes available up to that 50% threshold. Work is ongoing to look at what would be the optimal distribution of doses above that 50% threshold. Of course, there's the key question about when to go back to the older, more vulnerable individuals with a booster dose. And indeed, that may be required perhaps before immunizing some of the younger adult population if we want to minimize mortality. So there's work ongoing, but there are pretty clear guidelines for at least up to 50% coverage at this time. In terms of how countries will be supported in their modeling work, well, a nice thing from a lot of the modeling groups is that they have provided online tools. And of course, those tools are only really as useful as the training provided alongside. And I know that a number of groups will also be engaging with countries to provide that training. But it is rolling out country-specific models and providing them and providing the support is a major endeavor. I don't know, Raymond, if you want to comment on any other work coming out of WHO on that topic.
No, thank you, Nick. And definitely, I think that most, at least the modeling group, we have been in touch with through the RFP, but also the ones we are not, we're not in the RFP. Many modeling groups do have their tools available. They would like to have the models being used by policymakers in countries, in particular in low middle income countries. And it would be good that you also reach out to us and we can also then contact you with these different modeling teams to help you addressing the questions you might have. And as I said in my introduction, there are some groups who can deal with multi-model issues, but also really groups that are really region-specific or country-specific and can help you addressing the questions you might have in your countries. I think, Nick, there was also a question from Mohammed on the interval, and I think he was referring to slide 39 on the bias and flexibility to predict the bias and flexibility of the intervals using models.
Yeah, I'm not sure if Mohammed may be able to give us a bit more context for his question, but I think generally if the question is about what do we do when a model predicts something and then in real life something else happens, or what do we do if the model is projecting something at a certain time and then as conditions change, then we get a different result at a later time when the model is run with different inputs. So that's how I understood that question. And I think that is a challenge because the real world conditions are changing. But as Nick mentioned, each of the modeling groups has done quite a detailed set of sensitivity analyses. So one of the main things that we've tried to do from the SAGE working group perspective is say, how robust are these conclusions for policy to changes in the input assumptions? And as sometimes things have changed, for example, as Delta emerged as a variant with different properties from Alpha and the original strain, that changed some of the conclusions about what might be feasible, for example, in terms of lifting public health and social measures, and what levels of vaccination coverage might be needed to achieve certain of these other health and economic goals. So it is true that as the inputs change, sometimes the conclusions change and the policies change, but I think the modeling has helped characterize that and has also showed where there is more certainty around the results, even when those parameters are very varied widely. It can be the case that if we find that the conclusion is unchanged in spite of that variation, then we can be more confident in taking that forward to the policy process. So I think the modeling groups have done a great job of really exploring that and showing where it depends and where there's more certainty.
Thank you, Sarah. So can I propose that we perhaps move on to Nick Scott's presentation with some country examples, and hopefully we have then also some time after his presentation to go back to some of the questions in the chat. So Nick, please, the floor is yours. Thank you.
Thank you very much. And I just want to start by thanking all of the people who have worked with us on the different country examples that we're going to talk to. So there's some from Zimbabwe, Kenya, and Vietnam that we've done quite a bit of work with over the past probably 6 to 12 months. And so just summarizing a little bit of that here. Next slide, please. In terms of the questions that we aim to answer, really we focused on looking at schools. We also looked at topic 2, which was health system use and keeping health systems below capacity, and topic 3, which was the importation of infections and outbreak response vaccination. Next slide, please. So I won't go into too much detail, but next slide, please. Just to cover the basics of the model we were using. So we had an agent-based model. Really, we're simulating all of the individuals in the population. We have age-specific contacts. People can mix with each other in a number of different settings, and each setting carries different transmission risks. All of the interventions can be targeted by age or to different population groups. And we included a variety of countermeasures. So there were, as well as testing, contact tracing, diagnosis and quarantine, there were interventions, public health restrictions like the closure of schools or the closure of businesses, curfews, and these sorts of policies. Next slide, please. We also had age-specific mixing as well as age-specific contact structures. So the different network shapes in the model were different depending on where people would mix. And as an example of this, we have people mix in households in little clusters. People would mix in schools in clustered school environments, but also there were examples of people mixing in community settings that were much more random and can lead to the spread of COVID much further. Next slide, please. So I'll start by some of the work on vaccines and schools. Next slide, please. The two questions that we were trying to answer here to start with is, what is the impact of vaccinating teachers and school staff? And secondly, for comparable levels of vaccine supply, how does this compare to vaccinating other groups? And we approached this topic by, I'll show you the results for Zimbabwe, where we looked at a scenario with no vaccines and compared that to a scenario where all teachers and school staff were vaccinated to see what the difference was. And then we compared this to if the same number of vaccines were allocated to students or to members of the general population, or to the elderly, or to other key groups. Next slide, please. It took a little bit of effort to calibrate the model to Zimbabwe data. There were some obvious constraints in terms of missing data, and we just had to rely more on indicators like the known COVID deaths as a more relevant source, and also things like test positivity rates, and really working with the team to understand who it was that was being tested and how we could fit all the pieces together in the model. Next slide, please. These are the results of the first two aims. So the bar graph on the left shows the impact in terms of infections averted when different groups were vaccinated. Remember that this is vaccinating people with the same number of vaccines. And what we saw was that actually vaccinating teachers had the greatest population level impact in terms of infections averted. And there were a number of reasons for this. It's to do with the large number of contacts that they may have. They interact with students who can go home and also transmit further. So this is a population level thing. But if we look at the graph on the right-hand side, it shows the impact on hospitalizations averted from these vaccines. As we would expect, vaccinating people over 60 with the same number of vaccines had a much greater impact in terms of averting hospitalizations. But vaccinating teachers and staff still did have a greater impact than vaccinating the remaining under 60 population. So this suggested that they could be a key target for vaccination in this sort of a context. Next slide, please. We then looked at the question of school-based non-pharmaceutical interventions and what could vaccination do in terms of reducing the reliance on some of these and hopefully maximising more in-person schooling and reducing transmission in schools. Next slide, please. So we showed for different levels of vaccine coverage, each line here, so the blue line at the bottom shows for no school NPIs. We see for increasing vaccine coverage, what is the impact in terms of reduced infections in schools? And we see how this compares for higher levels of non-pharmaceutical interventions in schools. And so there is this sort of a trade-off where the higher the vaccine coverage we get among teachers and school staff, this can reduce the dependence on some of these other interventions. Or equally, it can be thought of as having a synergistic effect. Next slide, please. So the next topic we were looking at was vaccines, and using vaccines, really thinking about it from the health system perspective. Next slide, please. So what we wanted to do was, we knew that there was an allocated number of vaccine doses that were being rolled out per day. And we wanted to look at different ways of allocating these vaccines in the model. So compared to a counterfactual where the vaccines are just allocated at random through the population, we looked at a strategy of age targeting, with the exception of key workers who we vaccinated in the model first. Then there was a planned scenario. This was a part of the national strategy in Zimbabwe where they had a slightly higher prioritisation for people with comorbidities. And then we looked at various other scenarios where people with comorbidities were targeted in a different order. There were people at high risk of infection, so we included in the model people who live in dense settings, as well as looking at where teachers and students might fit in this mix. And so we ran all these strategies to compare the outcomes. Next slide, please. So this graph shows the reduction in hospitalizations as a result of these different vaccine strategies compared to a scenario with no vaccination. And we see that the one on the left, the no targeted strategy, this does the worst, and this is consistent with what all other groups have found. Really, it's age targeting that has a large impact. But then relative to the age-targeted scenarios, the other scenarios actually made relatively little difference. And if we go forward one slide, we see here we ran the model with double the number of vaccination doses, and actually compared to delivering doses faster or delivering more doses, these different allocation strategies didn't have a statistically significant impact. And this, I think, is unique to the context of having such a limited vaccine supply. Next slide, please. We also looked at what it would take, what level of vaccine coverage it would take to maintain or to keep COVID below hospital capacity. And we see these are grouped together with the use of non-pharmaceutical interventions throughout the general population to reduce transmission. And we see that really it's the first 20 to 40% of vaccine coverage that is the most critical in reducing the hospital demand. And this is really equivalent to saying that we need to vaccinate people over 60 in order to protect hospital capacity, and then we start to get these diminishing effects. Next slide, please. So the interpretation of this was that allocating vaccines in reverse age order drastically increases the impact they will have on hospitalizations and deaths. But beyond age targeting, these other prioritization strategies had minimal overall difference in terms of hospitalizations and deaths. But what we want to note is that any further prioritization should probably consider other factors. So there might be specific things about key population groups, and vaccinating teachers and teaching staff might be an example where infections in schools may be unlikely to lead to significant increases in hospitalizations and deaths, but it might have significant educational impacts for children. And so there may be other reasons to target vaccines to different population groups. Next slide, please. So the final example to talk about was some work in, this was in Vietnam, looking at the impact of vaccination strategies on preventing or addressing outbreaks. Next slide, please. And what we wanted to do was to look at firstly, the estimated probability of an outbreak occurring and the timeline that it might occur in. Then we wanted to know how many infections, hospitalizations, and deaths might be expected from an outbreak. And thirdly, what level of vaccine efficacy, vaccination speed, and coverage would be needed to control the outbreak. And this work was conducted at a time in Vietnam where there were very low cases, and we were looking at what would happen in the event of a Delta outbreak. Next slide, please. What we found, so we defined an outbreak as going from very few cases to more than 30 cases per day as just a detected diagnosis rate. We found that the ongoing use of non-pharmaceutical interventions or reducing the importation of cases through sort of travel or other restrictions had a much more significant impact than the vaccine coverage. So we're looking at vaccination coverage with the AstraZeneca vaccine to begin with. And if I can go to the next slide, please. And so these panels show the different, the columns show the importation of cases The rows show the level of MPI use in the population, and the dots show the time to an outbreak. And so we see that the vaccination coverage has some impact, but really it's the NPI use and the reducing the importations that has a greater impact. Next slide, please. We ran the same scenarios, but for an mRNA vaccine, and we found similar things, except that with the mRNA vaccine, once you start to approach the higher coverage, it does have this hook towards the end of the graphs, meaning that you can prevent outbreaks much better if they're in combination with some level of NPIs. Next slide, please. And this graph is showing that the expected number of deaths resulting from the outbreak and the consequences of it over an extended period. And really, it does show that the vaccine coverage can reduce the deaths as well, but all these other measures work in a synergistic way. Next slide, please. The last thing that we looked at was what could vaccines do as a response to an outbreak. And the rows in this graph show outcomes for infections, hospitalizations, and deaths. The x-axis shows the vaccine coverage before the outbreak occurs, and the y-axis shows the response, so the daily doses per day in response to an outbreak. And what we see is that there's very little gradient in the y direction of these graphs, and that suggests that the vaccination in response to an outbreak is unlikely to have any impact in controlling that outbreak. And this is the case because we know that it takes some time to develop immunity from the vaccines, and the speed at which a Delta outbreak in a relatively susceptible population could take off was much greater than the time it would take to develop immunity, particularly if the vaccine coverage was starting low and if it was a low efficacy against infection vaccine. Next slide, please. So that's a lot of information, and so I apologise if it's a lot to take in a short amount of time. Just to try and summarise it, really, we saw that vaccines across the countries we were looking in should be prioritised to the elderly and most vulnerable to protect the health system, followed by key groups who would benefit perhaps in non-health ways. And really it's the first 20 to 40% that had the greatest impact in reducing deaths and hospital capacity. Noted that vaccinations could also reduce a lot of the reliance on non-pharmaceutical interventions, which may have important economic and social consequences. In settings with low or no transmission, outbreaks can be delayed or avoided by minimising the number of daily imported cases or by increasing NPIs. And vaccine coverage has some but less impact on delaying outbreaks, depending on vaccine efficacy. And finally, improving vaccine coverage during times of low transmission is critical in preparation for future outbreaks rather than responding reactively. We really saw that having high coverage to begin with is much more effective than trying to catch up when something happens. So I might stop there. I'll just for any questions, and thanks very much for your time.
Thank you very much, Nick, for this excellent presentation from the countries on the several topics we discussed. I don't see any new questions in the Q&A. Perhaps I think there is a question by Mohammed on the 20 to 40% vaccination will reduce the hospitalization to which age group? I think he's referring to the slide in Vietnam.
Yeah, I can answer that question. So it was 20 to 40% vaccination coverage of the whole population, which corresponded to about 80% vaccination coverage of people over 50 years. So that's how that translates.
Excellent. So I don't see any other questions. I'm not sure we did have time to having perhaps some of the panelists to come in and to perhaps make some comments to one of the slides and the results presented. Give them an opportunity before I return to Corinne. So if not, Corinne, can you come in and guide us to the next steps?
Thank you so much. Thank you, Raymond, and all the presenters for the excellent presentations. Yep, so coming to the end of this session, I would like to open up the feedback pool to understand how much you learned from the session. So there will be 3 questions, and please, Echo team, can you put up the pool? And if you still have any questions, please put in the Q&A. We will answer you during the session. If not, we will answer you, provide an answer through email. Okay, so for the feedback pool, we have 3 questions. First, how after the session, do you have a better understanding of the usefulness of epidemiological models to inform global, regional, and national policies for COVID-19 vaccination? You can answer yes, somewhat no. And after the session, can you apply the COVID-19 vaccination modeling findings or the processes of using modeling in vaccination policy development for your own country setting? Yes, somewhat or no. And last, this is very similar questions. After the session, are you interested in applying the COVID-19 vaccination modeling findings or the processes of using modeling in vaccination policy development for your own country setting? So you can answer, yes, we'll do so. Yes, but technical assistance will be needed, somewhat or no. And again, when you are answering the questions, let's move to the next slide. I think you may go to a few slides later, please. Yes, so we will go to the slides for the material. Next. Next, yeah. Next, please. Okay, the next one will be right. So the slides coming up will be the slides providing you with the webinar materials, including the recordings and slides. Next slide, please. If you have further questions after the session, you can ask in the TechNet 21 forum or Telegram. And thank you very much for TechNet team for supporting. Next slide. And you will find the recordings of this session in English, French, and Spanish. And next Wednesday, we will have the last session on global status update. And please register through the link in the chat. And okay, before going to the last slide, and can Echo team please show the result of the poll? Okay, so great to see that more than 80% of you have the better understandings of the usefulness of the model. And then 43% of you think you can apply the modeling findings, and half of you think somewhat. Okay, that's good to know. And for the last questions, okay, good. Okay, more than 50% would like to use interested to apply the modeling findings in your own country setting, but half of you would like to have technical assistance. Yeah, thanks very much for the answers, and I think that's better for us to have a better planning for the next step. Thank you. Okay, go to the last slide. Thank you very much for your participation, and we look forward to seeing you again in the next session. And thanks for the translator doing the excellent interpretation, and the ECHO team, presenters, and all the colleagues supporting the session. And any questions related to the session topic that have not been answered will be shared with the technical experts, and the answers will be shared through email. And not sure whether Raymond, you have any last word?
Just to thank all the participants for the great questions, and also for the presenters and all the panelists being online. And it's good that this session is being recorded so that people who are not able to join us can look at this afterwards. Thanks again all.
Okay, thanks very much. We are on time and wish you have a lovely day. Thank you and bye-bye.
Bye-bye.